And then the next one, they talked about how the methodology of these papers be generated. These are not something particularly relevant for the owner, so I'm going to skip that. In section 3, where they talked about diagnostic approaches, these are maybe relevant. I will share a little bit of my input on reading this. So generally, there are different ways of cross-sectional images that you can look into the spine. You have the MRI, you have the CT or CT myelogram or myelograph. MRI is what they first mentioned. It's usually considered the best way to look into the spine. However, it comes with the problem with it takes a full anesthesia to do that, and usually takes much longer compared to a CT scan. Um, there are some additional information is MRI is prognostication in terms of predicting the outcomes. They do have some presence of some specific changes that have been variably associated with worse locomotor outcomes and development of progressive myomalacia or spinal cord necrosis. However, magnet strength, imaging plane, and observer might influence the reliability of these specific changes as a prognostic indicators. So even though it's generally kind of the preferred or the gold standard ways, there are some variabilities in terms of how we can usually use that. And in my personal experience, these prognostic associations are only useful when the dog is present in a worse clinical grading, which is the dog that has no ability to move and no ability to feel their pelvic limbs. Alternatively, we have CTs. CT is looking primarily using the X-ray beam to kind of circle around the body. They are very useful in specific subgroups of patients, namely the chondrodystrophic dog with mineralizing disc. So, namely, these are the Dachshunds, the Beagles, the Frenchies Bulldog, any dog that has a short leg and long back. These are kind of the typical breed that CT can be very successfully diagnosed with disc herniations. It is, however, less accurate in older dogs because they are usually coming with additional disease. Um, or very small patients, so less than 7 kilograms, that the resolution of the image are just sometimes hard to really differentiate that. And what you don't achieve is the prognostic utilities. So no matter how big the disc hernia, no matter how small the disc hernia, not necessarily always correlate with their outcomes and their clinical gradings. What is really cool about this consensus statement is they highlight all the kind of the most helpful information in the gray box. So, um, and myelogram, CT myelogram is something that it's described in the book, but in the last 5 years, I only had to like do one time because the CT wasn't or the MRI wasn't working, so we have to do a CT myelogram. I would say 95% of the neurologists right nowadays probably are not using this anyway. So, so here's a summary. When extruded material is mineralized specific in young to middle-aged adult chondrodystrophic dog, dachshund, Frenchies, beagles, etc., CD is usually sensitivity enough in making a diagnosis and treatment planning. MRI can provide definition of additional intramedullary lesions or specific changes that tells you how much of the injury that the spinal cord sustained. But what I found probably most helpful is when a case presents to you, you're worried about this may not be a disc herniation, this may be something else. It's very, very helpful to make a diagnosis other than intervertebral disc extrusion. And that sometimes we may use MRI more preferably than a CT. So it goes into a little more details. I don't think it's going to be particularly changing how we manage cases. So we will stop here. And then we'll move on to our most important topic, I think, is how to decide medical or surgical management.